Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we'll talk about corneal and external eye referrals. I would encourage you to watch the first episode in this series, which covers the generic information that we should include in any ophthalmology referral. That talk will underpin all the episodes in this series. I would also like to remind you that this is how I would process a referral for a patient with a corneal or external eye condition, and you must of course use your own professional judgment and follow any local and national policies and guidelines which are in effect. If you're unsure, then you should seek professional advice. I've chosen to combine this talk to cover both the corneal referrals and the external eye referrals because there is quite a lot of overlap. But do remember, when you complete your GOS 18 form, you will have to choose one or the other. So for external eye referrals, first of all we're talking about non-oculoplastic eyelid problems, so primarily lid margin disease as well as dry eyes. We're covering also conjunctiva, all the various types of conjunctivitis, and also the sclera and episclera. From a corneal perspective, that is really a subset of external eye, you could say, and those corneal conditions will broadly break down into one of these four categories. It'll either be corneal edema, it'll be infection stroke inflammation, it could be a corneal dystrophy such as keratoconus, or some scarring, loss of tissue. What I'm not going to be covering in this talk are those conditions which may be sent to an acute service or eye casualty. I'm well aware that some of you may well manage these yourselves, but for the majority of referrers, these will be sent on to somebody else. Let's start off with the basics. First of all, as far as the patient's symptoms are concerned, we want to know which eye is affected, when did it start, and specifically how does it feel. Try to differentiate between pain, which you might want to give a grading perhaps on a scale of 0 to 5 or 0 to 10, just make it clear either way. Is it itchy? Is it gritty? Is there photophobia? And these will point to quite different potential diagnoses. Does the patient have a history of contact lens wear? And in terms of the clinical signs, is the eye red? How's the anterior chamber looking? Is there any activity there? And specifically in the context of a corneal lesion, where is it? So broadly, is it central? Is it peripheral or mid-periphery? And does it stain? Intraocular pressure and pupils will be more relevant in some conditions rather than others. Cornea and external eye does cover a broad range of conditions, and arguably these things will be less relevant in, for example, a dry eye patient than they would with somebody with potential acute anterior uveitis. In terms of imaging, it's really helpful at the very least just to have a single image, macro image of the affected eye, so that the person receiving the referral can have an idea of what it is that the eye looks like and what they're up against. What should we try to avoid in these referrals? Well, really any vague statement such as, the patient's had a red eye for a while, please assess, without really backing that up with any more specific symptoms or any other findings. A routine referral to exclude a corneal ulcer. Well, if you think somebody has a corneal ulcer, particularly an infective ulcer, then you really want to treat that as such until proved otherwise, and the patient's going to be referred on a far more urgent basis than routine. And perhaps you feel a patient may have keratoconus, well that's fine, but you just want to give a bit of evidence as to why you think that may be the case, and we'll talk about that on the next slide. Once we've got the basics right, we may look to upgrade our corneal and external eye referrals. In terms of the history, is this something that's recurrent for this particular patient, or is it the first time? Are they atopic or prone to allergies? And do they have any systemic disease that may be associated with the ophthalmic presentation? In terms of signs, you want to avert the lid and comment on the tarsal conjunctiva. You want to comment on, for example, whether lid margin disease is present or absent, the tear film if the eyes are dry, and specifically in the context of corneal pathology, the size of the lesion, which you can measure with a graticule, or if absolutely necessary, you can measure with a ruler held close to the eye carefully. And the depth of the lesion, which with an optical section, you can at least say whether it's epithelial, stromal, or endothelial. In some cases, you may wish to measure corneal sensitivity. It's helpful to make a note of any treatment that you've tried, so what's been effective and what hasn't. And in terms of imaging, we can go a step further here. So a macro image showing both eyes for comparison, then an image of the affected eye, both with and without stain, and although it can be quite difficult to do this, a slit image to show any corneal pathology and the depth can be extremely useful. Just to touch briefly on keratoconus, it's very helpful to note any known keratoconic signs. If you have a corneal topographer, of course, that would be your gold standard. And if not, if you can measure central corneal thickness and even include your K readings, then that's going to most probably give a certain amount of evidence to support your tentative diagnosis of keratoconus. Thank you for watching this short presentation on corneal and external eye referrals. Next time we'll talk about low vision referrals. Thank you.